Hi, everyone. My name is Emily Holmberg. I am the Director of Human Services here at McKenzie. And I would like to introduce or welcome all of you to our Healthy Living Together event today. We have Rebecca Stoliker here, who is going to be talking about stroke awareness. So what is a stroke, how to identify it? We're going to get lots of knowledge today about stroke awareness. And so thank you all for coming. I just want to give a quick reminder, next month, November 19th, we have our next Healthy Living Together event is November 19th, and it is on self-care during the holidays with Tabitha Jensen at CMH. So, thank you, welcome back.
Thank you. So thank you, Emily, for the introduction. My name's Becky. I'm the Director of Nursing here at McKenzie, and we're going to talk about stroke awareness. I personally have not had a stroke, but I've seen lots of them. And I guess what gives me the right to speak about this today is that McKenzie Health System is an acute stroke ready hospital. So way over 10 years ago, we partnered with Extension and brought telehealth providers in so we could have neurology consults here, give medications, and recognize that obviously in rural America and Sanilac County, being rural itself, that our distance to an intervention, our distance to a neurologist for interventions can take quite a bit of time. And so this was us bringing some of that specialty services here for early definitive care and next steps. So stroke awareness, the acronym that we use to be prepared for stroke is F.A.S.T. Has anybody heard of F.A.S.T before? I'm guessing you maybe have heard of F.A.S.T. It was shorter, post-COVID, they made it longer. So F.A.S.T was face, arms, speech, and time. So we'll look at F.A.S.T. And look at what a stroke actually is, how to recognize a stroke and signs and symptoms, what to do if you suspect a stroke, either for yourself or for someone else, and why time and early action is needed. And then lastly, and probably my biggest focus, and if you want me to adjust, I'm happy to do so, but how do we empower the community? How do we take care of our friends, our family, our loved ones, and hopefully prevent strokes? Because really that's the best defense we have. So what is a stroke? Stroke is a brain attack, essentially. The American Stroke Association coined that term, if you will. Other words for stroke: brain attack, CVA, or cerebral vascular attack, cerebral infarct, or ischemic stroke, hemorrhage, intercerebral hemorrhage, or an intracranial hemorrhage can cause a stroke as well. The brain attack has been adopted because it really helps people pull together that it's an issue with your brain and time is of the utmost essence. So stroke is really a complex disease that occurs when either a blood vessel is clogged off. So we see here plaques, like if you had high cholesterol, like narrow that artery or roadway, if you will, that carries your blood. And then if you have a clot, it's going to come into that hole and plug it, just like your garden hose, and not be able to get water through. That can cause a stroke. Or a hemorrhage, as the name suggests, is a rupture. So maybe you have an aneurysm that ruptures, an injury that causes one of your blood vessels to get hit and open up and it starts leaking blood. That's also going to cause a stroke. So when we talk about stroke, there's really two distinct differences, but both is complex in that it messes up your blood flow and prevents blood flow to your brain or to that area. So the longer someone's without oxygen to the brain, to the lungs, wherever, the shorter their lifespan is intended to be, right? Because we all need oxygen. So strokes can result in disability or death. We've gotten really good at treating strokes, so we've reduced the our death rate, but then that also leads to more issues and concerns after the fact. So again, that's my plug back to prevention, but essentially that is a stroke. Two different types of stroke are hemorrhagic, which is bleeding, or ischemic, which is death. So your hemorrhagic is going to be a rupture of a blood vessel, your ischemic is going to be a blockage that prevents blood flow. Of those blood flow issues, that's the majority, 87% of strokes are caused because of a blood flow issue or a blockage. That could be from heart disease, that can be from a clot, that's a large percentage of just unknown, the how or the why behind it. Or an LVO, which is a large vessel occlusion, again, if you have a large clot that goes in and it's affecting the main stem, think of a tree. If it affects it at the base of the tree, the rest of the tree branches aren't gonna get nutrients that it needs, or in this case. Does that make sense? I don't wanna get into the nitty gritty. I try not to make it all bloody or gory or anything, but that kind of stuff serves me. So how do you recognize a stroke? I talked about F.A.S.T, it used to be F.A.S.T, face, arms, speech, and time, now we've added balance and eyes. So sudden loss of balance, sudden loss of vision, sudden drooping to one side of the body is more common than another. Speech that isn't quite clear, all of those sudden changes are your earliest recognitions of a stroke, if you will. Sudden confusion or trouble comprehending or understanding what's going on. So we'll break each of these down into a slightly bigger picture. Balance. So you're walking along in Walmart and you see somebody, or maybe you're with your significant other or a friend, and all of a sudden it's like they're tripping or they're dragging their leg behind them, having problems keeping their balance. How are they walking? Is that abnormal for them? Is their gaze steady? Is there dizziness or an inability to walk where they want to go? Like I'm trying to get here, but there seems to be a disconnect maybe between what your mind's trying to make your body do and what your body's actually doing. That balance component of the F.A.S.T is the way that we can recognize a stroke. Some people also have seizures, so there's some recessors to those as well. The next piece is E for eyes. Is there vision loss? What are both eyes? Is there a change in their visual field? Maybe there'll be double vision. Instead of your eyes tracking something or looking at something and both going in the same direction, maybe they're going in opposite. I can't make it go opposite, but I can make them come together. There's fun fancy names for those, but if there's light intolerance or a change in how they're seeing and that seems to be sudden, that's another indicator of a potential stroke. Face, this goes back to one of the basics here. Again, ask someone to smile. I find that I have a slightly crooked smile, but like I said, I've never had a stroke. If you notice a droop on one side, like there's not enough muscle pull to make the smile symmetrical, that's a huge sign of a stroke. If there's weakness or drooping, if the face looks uneven, sometimes people will get nauseated and vomit, so there might be something leftover residual on their face even. That's another big indicator. So a lot of what we see is loss of function and ability, loss of sensation. And many times that affects one side of the body versus the other. Looks like you had a question. No? Next in F.A.S.T is A for arms. We ask people to hold their arms out in front of them. It's the easiest thing to do, right? But if one starts to drop, it means that they have loss of tone or function in that arm also. So maybe somebody isn't able to hold both of their arms out equally, and that's abnormal for them. So as I get older, as I get tired, maybe I have an injury that's known, but for the most part, we should be able to function the same on the right as the left. And so having that drift that we call where one drops or isn't able to stay up is a telltale sign of a stroke as well. Again, moving all extremities. So when we talked about balance and their gait or how they walk, if they're not able to lift their leg and pull them with them, that's going to change their balance, their gait, their stride. It's also going to show you that they can't move all of those extremities. Sometimes they can see it. They can see my hands here and I'm trying to reach for the salt, but I can't do it, but I can do this. Recognizing and feeling all of your extremities is also normal, so if that becomes abnormal, that is another sign of a stroke. And then S is for speech. Asking a person to repeat a simple phrase, the sky is blue, today is Wednesday. Any of those things that sound strange. Is the speech slurred? Is it slow down to the point that someone might notice? Is it garbled, or they have marbles in their mouth and you can't quite understand what they're saying? Again, that goes back to muscle tone and losing function. Your face is quite small, but there's a ton of different nerves that go into it to impact your eyes, your face, your speech, all of those cranial nerves. And so depending on where that blood clot or bleed is, depends on which sign or symptom you're seeing in somebody that's having a stroke. Are they using inappropriate words? We call it word salad. If I'm trying to tell you about the salt shaker and I say the next to the table with a salad. You can't follow it, and normally you can. That is another speech issue or concern. Again, appearing to understand conversation. A lot of times, even if people don't, if I'm having a stroke and I don't recognize it, I'm gonna get frustrated that I can't understand. I was just hearing a conversation on with Emily and now I can't. And so you might see some of that frustration there too, or maybe they've been by themselves and you're just stopping in to check in or have a visit and you notice something different is off. And they might not be able to recognize how long ago that started or happened, or maybe they wake up in the morning and it is how it is. So speech abnormalities are another sign recognition of stroke. The last one is T for time. And while this isn't something we're gonna assess on an actual person, it goes back to how long have these symptoms or this symptom been going on. A lot of times it's not just one, but it may start out with one of these. So if my mom comes to visit me and I'm no longer talking like a normal human being that I normally would, when was the last time I was normal? So, hey, children, how long's mom been acting like this? Knowing the time of the last normal is essential for all of the next steps that come to be. Medications that we can give depend on the time of the last known normal of that person. The interventions as far as surgeries go, putting in a stent or opening up those blood vessels again, your chances of improvement significantly decrease as time goes on. And I'm kind of getting ahead of myself, but stroke symptoms can evolve over minutes, over hours. So catching it as soon as possible, knowing when those symptoms started and when their last normal was is a huge, not only indication of a stroke, but hugely important for next steps going forward. Any questions so far? So recognizing a stroke, again, condensed version, nausea, vomiting, double vision, dizziness, vertigo, or like a ringing in your ears, dizzy feeling. A lot of times people have difficulty swallowing, so maybe I'm eating my quesadilla or I ate my quesadilla. What is everybody's eating their soup? I've eaten my soup, but I'm kind of choking on it because I'm having a hard time. Again, if I'm garbling my speech and I can't talk clearly, am I going to be able to swallow clearly? Probably not. And that can cause additional issues, right? Because then maybe I swallow my food, it goes into my lung, now I have pneumonia and all these other things going on. So again, time is essential. Loss of sensation or ability to move or function in any or all extremities. Hiccups is an abnormal presentation, but not that you need to go to the emergency room every time you have hiccups, but just recognize that there's other strange things out there as well. If it's a bleeding type of heart attack or hemorrhagic, people will come in and they'll just complain of a headache. It's the worst headache I've ever felt. Like, maybe I've had a history of migraines, maybe I haven't, but 9 times out of 10, that headache is the worst headache ever. So having something that abnormal is a sign as well. And then again, decreased level of consciousness or inability to arouse or converse is normal. and other neurological deficits. So, be fast, balance, eyes, face, arms, speech, time. Be fast, and be fast to make sure that we're doing it in time. You recognize a stroke, then what?
About 911.
Yes. EMS crews will come out, and EMS crew will come out, you call 911. They're gonna recognize those same signs and symptoms, they're gonna do the same sort of assessment in addition to their medical assessment. And they're gonna notify the closest emergency room that we have a potential stroke. And that's the,
What if you can't show up? I mean, you dial 911 and they'll just come.
I mean, I never worked for dispatch, but generally speaking, if someone dials 911 and they try to talk to them and they can't get anybody, they might try to call that phone number back. Or they'll listen for background noises, and usually they'll send an officer to that location just to make sure everything's okay. I've had my camping chair accidentally squeeze my cell phone and call 911, that's embarrassing. And I get a call back from the area dispatch, are you okay, did you need anything? Nope, I don't, I just gave it to my child or made a mishap, whatever. So they do their due diligence to see if there's an actual emergency or if there's not any, so. So EMS notifies the local ER that there's a stroke alert, a potential stroke patient. EMS has their own protocol, we're gonna get an IV, we're gonna check your blood sugar, make sure it's not your blood sugar being low. Ask you lots of questions, continue with that assessment. A lot of times, if you come to McKenzie, we're gonna go straight to the CAT scan room. Doc will be there, nurses will be there, a whole plethora of people will be there to say, hi, how are you? And let's ask you a bunch of questions while we're getting you in there to get that scan. So everybody's focused on the ticking time clock that is, to hopefully prevent disability and death. So. 911, we do have people who just show up, and that's fine too. Obviously, the sooner you get medical help, the better, and so I advocate for 911 and our emergency response systems. If I lived across the street, or if I was at the church across the street and something was happening, maybe there's somebody that can help me get over here and that's going to be quicker. That's a risk game that I always fail at, checking out in the grocery store in the wrong lane every time, right? I always choose the slower run and inevitably I fail. But calling 911 gets you immediate medical assistance as quickly as possible. And interventions that you can't do while you're walking or being carried across the street. So strokes are emergency, call 911, call the ambulance, get on over. Why? We all live in Sanilac County, right? Most people won't recognize the signs of a stroke, or worse yet, in my opinion, worse yet, deny it. Oh, I must have twisted something in my leg and that's why I can't move it the way I'm supposed to. I'm just tired, I laid wrong, I this or that. Trying to push some of those things aside, but again, time is essential. And so getting services as quickly as possible. When we live in rural Michigan, I don't have to deal with the traffic and the hubbub of the city. But we've got over 40,000 people and over 1,500 square miles. That's a lot of space. That's a lot of space for EMS to cover. We have 3 critical access hospitals in our county, which we are blessed to have. We have 3 EMS services, which we are blessed to have. They're all spaced out throughout the county to hopefully decrease those response times. But the American Heart Association said this year in our research, that rural Americans are 30% higher risk of stroke and 40% more likely to develop heart disease and live an average of 3 years less than those who live in the city or in urban areas. And a lot of that is connectivity to healthcare. So when I build my house, where am I at in relation to hospitals? Where am I at in relation to EMS? When I think about retirement, I'm like, oh, it would be really nice to live on the lake shore. How far away do I want to get from this town or this town? Because in my mind, I think, how much farther does that ambulance have to go to get there? I'm straight, but it is interesting. And then the longer the time progresses, the worse your outcome or symptoms usually are as well. So we live in rural Michigan, that's a risk in and of itself. Pre-hospital, Sanilac EMS is one of the 3 services in the county. They cover a majority of the county. We have a station here in F.A.S.T, one in Deckerville and one in Carsonville. Carsonville is usually busier in the summertime when there's lots of things going on in Fort Sanilac Way. That construction has been a booger. But it can impact those response times too. So we all kind of cover our own areas to be able to get to help as quickly as possible, or get you to help as quickly as possible. So Sanilac EMS with Sanilac Med Control works with other hospitals in the area. We develop protocols, we develop standards of care, we monitor those things, look at the quality to make sure that we're providing the best care possible. And every time we have a patient who comes in with a stroke or a potential stroke, we're taking a look at those things to see what can we do better next time, what can we do well, where can we improve that. So we're all one large team, pre-hospital, in-hospital, post-hospital, working together. When you get to the hospital, and I'm gonna buzz over these things because it's really not how to recognize the stroke, but what to expect. You're going straight to the CAT scan, you're gonna be put on a hard board, and we're gonna take a picture of your head at the same time that we're asking about 15 different questions for a stroke screen. As well as checking your blood sugar, we're doing additional labs, lots of people all at once. That CAT scan is super important because it tells us if there's a bleed in the brain or if there's not. So we said that brain bleeds are the smaller percentage of strokes, right? 13%. But if we have a brain bleed, we don't want to give something that makes us bleed more. That'd be a really bad thing. So let's rule these out first. And if not, and you're having a stroke, we can give medication, TNK, to break up that clot. And I swear to goodness, it is unbelievable to see that medication. I've seen the medication pushed, and within 5 minutes, you're regaining abilities that you didn't have when you came into the emergency department. And so time is essential. The quicker you can get that in, the better. That's our best line of defense in Sanilac County, honestly, because we have at least an hour to get to any other hospital. So wherever you live, that's probably the best option for us if we have a stroke, but making sure that we don't already have a bleed or something else going on. You can have this medication and you can still have surgery if needed. So maybe you have a large clot that came off and it's stuck in your blood vessel, and we're gonna treat it with the medication to help bring it down, but there's maybe more than one of those. And so we can still send you to St. Mary's or Michigan, or to a neurologist somewhere else that can do definitive surgery and open up that area and recreate blood flow in addition to it. So medication's first line of defense, I'll say, after prevention, and then afterwards surgery as needed. But we're doing labs, we're asking lots of questions, we're making sure that you can swallow okay before we ask you to swallow any pills, right? Because we don't want to cause more problems than we already have. And then again, education. So I mentioned at the beginning, we've been doing this acute stroke ready hospital for over 10 years. We established it with St. Mary's, which then became Ascension, which then became Michigan now. But looking at policies, making sure we're involving other departments, we have agreements to be able to get you quicker to another facility, to kind of get rid of some of that red tape, I'll say, to be able to continue care elsewhere for those thrombolytics medications that we gave. And then we also have teleneurology, so I mentioned that briefly also, but after we do the CT and we get you back to your room and we're still asking you questions and hooking you up to everything under the sun, we're gonna put a computer screen in front of your face with a neurologist who comes on that can assess and ask questions and see what's going on. The nursing and the doctors that are here are able to help facilitate that, asking you to hold up your hands. And now we're gonna close your eyes and see if you have a drift after we count to 10 seconds or whatever the case may be. That neurologist is also looking at the CAT scan and what the risks versus benefits are to giving that medication. We want to take a look at your blood pressure, make sure that that's under control, because if we just focus on the stroke and there's something else going on, then we may miss something else or possible issues. So timely transfer. Again, time is brain compared with the rate of brain loss of normal aging. If you have, a stroke. The brain ages with a stroke equivalent to 3.6 years for every hour without treatment. So from the moment that the person starts to have symptoms, that's when that clock starts ticking that I was talking about, and every minute counts. And I have a better picture, here it is. So the first 3 hours are huge, but this is a brain that 10 minutes after the stroke, you can see the red area, and that would be, let's call it brain death, that there's no blood flow to, and then the green is still impacted, because like that tree, if you don't have blood at the base of it or water at the base of it, it can't get out to the rest of the branches. So red is death. Green is, let's keep an eye on this, and you can see in an hour how that red spot just increases in 3 hours and 6 hours. So now everything that started from that tiny little branch has now impacted that much of your brain. So help, quick help. And that's why we ask time frame, because some medications will work to 3 or 4 hours. Surgeries are usually good within the first 24 hours. If you find somebody or you come across somebody that we don't know when their last normal is, we're gonna still go through all the measures and try and figure out that what the time frame is, but also to be able to give them the best help possible. Every minute of a large vessel occlusion or death of a cell destroys millions of neurons and synapses that connect those neurons and all of the covering and coatings within your brain cells that help make them function and cause my brain to feel this and know that it's a hard table. And so every minute, times brain. So the clock is ticking. We can give thrombolytics or that clot busting medication within 4.5 hours from the first onset of symptoms. So we say you call 911 at 4:30. What time did these symptoms start? About a half an hour before. Okay, so 4 o'clock is when that time starts ticking. So ideally, I can get these IV medications by 8:30. Interventional radiology or surgery to be able to put, I talked about like a stent or a balloon. They would actually come in with a wire catheter and they push out the blockage in the vessels and then open it back up. So I don't know how well you can see that, but it allows for blood flow to go back through. Best results within 24 hours, again, sooner the better. So even both of these things combined is going to be your best bet for treatment. So what can you do? We can recognize a stroke, we can take action and call 911, seek treatment immediately. What else? Education, so things like this, learning, asking questions, reducing risks, recognizing signs and symptoms, which we talked about, making sure that we're advocating for ourselves and others to get early intervention, and managing our chronic conditions. You have high blood pressure, if you have an abnormal heartbeat, all of those things can increase your risk for stroke. So stroke education, we have handouts, I have magnets at my house with a F.A.S.T on it. That is a visual reminder, we put stuff out on social media, we have lunch and learns. We do inside training at the hospital, but we also go outside to do education as well. And we follow people every chance that we get to be able to help understand the signs and symptoms and recognize them early. Talked about the CT a little bit already. And timely transfer, so getting out of here and getting to a higher level of care that can do those surgeries and have an MRI or EEG or other studies that we can't necessarily do here are extremely beneficial. There are times that the medication is enough and monitoring the ICU for bleeding for a short period of time is appropriate before follow-up for that. We do have quite a few patients that come into McKenzie with stroke symptoms. They have their stroke, we give them their medication, they go on to the next level of care. They see their neurologist, get all this game plan, they come back to us for swing bed, gain their strength and abilities back, and then go home with home care and continue to progress that way too. I mentioned before, my favorite thing is prevention of a stroke, because there's a lot of time, effort, money, everything that goes into fixing what strokes do. Have you heard of a TIA? Transit ischemic attack. I didn't mention that before when we talked about stroke because it's not the same thing. These little guys are warning signs. 40% of people who have a TIA or a transit ischemic attack, which looks like a stroke, but it resolves on its own. It's like when I have to hit the restart button on my computer because it's not working and maybe it's technical user error, maybe it's not. TIAs are your warning signs of a stroke. Your wake up, your coming to Jesus, whatever you want to call it, opportunity to hopefully prevent a stroke, but knowing that if we have a transit ischemic attack, which is stroke-like symptoms that resolve on their own, that you're gonna have a higher chance of having a stroke. So lots of times, right, like we err on the side of caution, so I come in, I think I'm having a stroke, I don't. By the time we get the CAT scan back, Becky's talking normal, she seems to have her functionality back, maybe some numbness or tingling that's resolving in the hand. That could be a TIA. And I would be suggested to have an MRI that day, next day, later follow up, just to see. Maybe that's because my blood vessels are starting to clog and I couldn't get enough blood. But it resolved and it was okay. But if I don't do something about that now, it might end up changing and be worse the next time around. Risk factors. I talked a little bit about chronic conditions. There's a whole lot of information on here, but diabetes, pre-diabetes, heart disease, smoking, not being physically active, having high blood pressure, not getting enough sleep at night can put you at risk for cardiovascular disease, which can put you at risk then for stroke. So knowing what your risk factors are, and I really like to differentiate what you can fix versus what you can't fix. Risk of stroke, high blood pressure, diabetes, heart disease, high cholesterol, smoking, drinking, age, ethnicity or race. African Americans are more prone to stroke than Caucasians, bleeding disorders, vascular malformations or abnormalities. The biggest risk factor of all is uncontrolled blood pressure. So I ask you, if you are on a blood pressure medication, please take it. Talk to your doctor before you stop taking it.
What's a high blood pressure?
Anything over 120/80. So depending on the rest of your health and your risk factors, you might look for that to be lower or more condensed. But generally that's our cutoff to say that it's high as 120/80. So some of these things I can control, some I can't. Right? Stroke is preventable. 80% can be prevented with healthy behaviors. Again, those long-term effects of a stroke, such as disability and losing functionality, can be minimized the earlier that treatment is sought and intervention is completed. So more and more people are surviving a stroke. I don't always know what that quality of life looks like, and nobody can shake a magic 8 ball and tell us what it's going to look like. But we can get you through it. Even better is to prevent it from happening. So lowering your blood pressure, lowering your cholesterol, eating healthier, stop smoking, drinking in moderation, all of these fun things that we hear at least annually, probably from our provider when we go in and see them, right? Reduce your stress, control high blood pressure, consume less sodium, lose excess weight. They say if you can lose 10% of your body weight, if you're overweight and you lose 10% of it, it's just a huge difference. Women are at a greater risk than men. Being over the age of 65 puts you at greater risk as well. Don't use illicit drugs. If you're given medication for any of these things, please be compliant in taking it. Or if you have an issue with taking it, have that conversation with your provider. I mean, nobody wants to be miserable. If I'm taking a blood pressure medication, but it makes me so tired and I can't even get up, well, then I might need to just adjust my dose, and that would be a lot better for me preventing a stroke than it would be if I just stopped taking it altogether. After a stroke, discharge planning, the goal is to make sure that our patients are safe. Whether they go to swing bed or a nursing home or home with home care to rehab. Nurses and providers work with all other disciplines to help manage those residual effects, so those leftover pieces that cause disability, and also help prevent recurrent strokes. What can we do? Like I said, 80% of stroke is preventable. Up to 80% of second clot-related strokes can be preventable. Once you have a stroke, you want to prevent additional strokes. So again, knowing your risk factors and what you can change. Of the things that we talked about, what sorts of things do you think you can't change that are risk factors? I can't change my age, right? Unless I have other issues besides stroke. I'm gonna go out on a limb and say that I can't change my sex. I can't change my race or ethnicity if those are already predisposed to me, but I can do other things. I can't change my family history of a stroke. Right? What I can do is I can modify my other risks to hopefully reduce them. I can control my blood pressure, choose how much tobacco, alcohol, other drugs I decide to use. I can maintain my weight, work on losing weight. That's another healthy lifestyle. Increase my activity, manage chronic conditions, again, take medications as prescribed, and nurses are the worst for those things, so I get things they want. If you wanna lower your risk, they say, the American Heart Association, if we do all 4 of these behaviors, we will have 2.3 times less risk of a stroke. So not smoking, being physically active, limiting alcohol, and having 5 servings of fruits and veggies a day. A lot of our risk factors for stroke are the same as for our heart, right? And I talked about cardiovascular disease, and having one of those leads to the other. So if this sounds repetitive, that's because there's lots of great things that we can do to make ourselves healthier every day. Shouldn't just. I would also ask to find your why. If you need to change these risks, and you can't change your recognized risks, but you can modify some things. What determines that Becky's gonna do that or Becky's not going to do that? It's my why, what's my reasoning for those things? I wanna lose weight because I wanna be able to play with my kids outside and not feel like I'm short of breath. I wanna go to a family member's wedding and look good in a dress or be able to dance with them on the dance floor. Any of those things. Find your motivation, find your why, that will help drive what you do, and it'll help show you what that's gonna look like in your life, change it a year from now, 5 years, 10 years from now. One of my whys for making health changes is that I didn't wanna become diabetic in my 30s, like that's a family risk factor for me, which also leads to a risk for stroke, which has also happened in my family. But I wanna be here for my kids when they graduate high school, and I wanna be able to play with them, and I wanna be healthy to do those things. And I wanna try to embody health while I, being a nurse and trying to share health with other people. So what's your why? And just remind yourself of that. Healthier eating, we talked about, servings of fruits and vegetables. This My Plate planner goes way back to kindergarten days, and it's come back around again. Filling half your plate with vegetables, a quarter of your plate with lean meats, chicken, burgers, maybe burgers from here, but not fast food pieces. A serving of fruit, having your milk, having a colorful plate and a proportion plate will help with, healthier eating, will help with your cholesterol, will help with all these other things. It's this. Reduce your sodium. Sodium is salt. My house eats tacos on Tuesday because it's easy and my kids like them and it's the one thing we can agree on. I make my own taco seasoning because what's not on here is salt. But it gets the same great flavor as it does from opening up a packet or buying it from the store and shaking it on. I reuse it, make it in bulk, but reducing our salt intake, little bits like that. getting rid of this guy and not even putting it on the table is helpful. What else can you do? You can exercise. It lowers your blood pressure. It helps you reduce stress. It reduces obesity, cholesterol, improves diabetics. It can lower your risk of stroke. Exercise includes things that you have to do anyhow, like washing the floors, vacuuming, walking the dog. And things that don't even feel like exercise, playing with the kids, with the grandkids, dancing. Going for a walk, pushing a stroller outside, doing your grocery shopping. I don't know about you, but I love Walmart grocery pickup. And it saves me a lot of time, but I feel like I can tell the difference when I Walmart grocery pickup versus when I just push the cart and walk through the store. Exercise increases your heart rate. It should be done regularly. Doesn't mean it has to be done every day. If you can do it 2 to 3 times a day or 2 to 3 times a week, let's not get overboard. 2 to 3 times a week is great. Regularly 15-30 minutes each time. And what increases my heart rate is gonna be different than yours because of what I'm used to doing. So I'm not telling everybody to go out and run a 5K. I'm not doing that. I don't know that anybody in this room should be doing that without consulting a provider first. Quit smoking. Drink lots of water. There's ways to help quit smoking here. There's benefits of it as well. There's resources out there all over. Ask for help, find a buddy, start hanging out with people who don't smoke or who want to quit smoking. There's apps, there's texts, they'll tell you every day something positive and keep you to quit. Priority number 1 is prevention. Blood pressure, cholesterol, blood sugar, being active, eating better, losing weight. You didn't eat all of your lunch. Losing weight. Don't smoke. Talk to your doctor about aspirin or other medications if you're on a blood thinner. Talk to them about that as well before you decide to change it or go off of it. All of these things will help prevent additional strokes. Will also help you prevent having a stroke to begin with. So recap. What's a stroke? Something bad that happens to your brain. Brain. How do we recognize the stroke? F.A.S.T. F.A.S.T. Yes. Be fast. Once the stroke's recognized, what are we gonna do?
Call 911.
Ghostbusters. Yeah. Call 911. Get an ambulance. Make sure you're keeping track of the time. So we can recognize them, we can advocate for people. Don't wait, just go and get it checked out. You're having high blood pressure, it's been high, you should really talk to your doctor about that, consider making changes. Stay healthy. I really like this guy. It's a little too early for it, but all in all, lose some weight, quit smoking, move around more, and eat the carrot for your fruits and veggies on your golden. Questions?
What if you can't have an MRI?
You don't have to have an MRI. Some people can't because of having implants or other metal pieces in them. CAT scan is the #1 way to go. You do a CAT scan and it doesn't show that there's a bleed and you're following up the neurologist and they want to do an MRI, but you can't. They can do different studies, electrodes on your brain to be able to monitor the electrical function. To be able, you can do PET scans. You can do other MRIs where they look at the blood flow by itself, called a CTA, to see what those look like. I haven't heard or known of anybody just to go on and probing around, looking around for stuff, so that's.
I have a bracelet that said no MRI, and I had it right on my wrist, and I went to the hospital, and they said, can you take that off, put it on the other end? Never even looked at it.
That one of those like silver medical alert bracelets, okay. So it is part of the screening if you're getting an MRI, I mean. To do an MRI, there's a whole page of screening questions for things, but those are great to have on. We're also doing a lot of file of life, like our community paramedic program has started putting those out more in the community, and so just like your medical alert bracelet is supposed to alert me that there's something going on, whether you're.
That's what I had it out there for. And I was gonna have catheterization, if I have. And it's gonna put this on, and I had it, that's where I had it. He can take that out for over here. Never even looked at it, see what it was.
I wonder if it was in your chart somewhere, or it would have come up later.
I
you
tell
know.
the doctor that I can't have an MRI. Cause I got two metal implants in the ears. And also, what is too low or too high for, too low for cholesterol?
Now you're pulling, I sat behind the desk. Actually, every lab has a different reference range for that, and it depends on if you're talking about good cholesterol, bad cholesterol, total cholesterol. And what you normally run, because you making an improvement on bad cholesterol might be better than my normal cholesterol is on an everyday basis. So I'm gonna defer that one back to your doc.
I understand you have to have so much cholesterol for your brain.
Mhm.
Have enough there, that's a disadvantage too.
Yep, so there's different types of cholesterol, your HDL. Is high density, that you're happy, is how I remember it, where you're good cholesterol, you want that to be higher. And usually it gets up with exercise rather than medications. Your LDL is your bad cholesterol, which again has to be at a minimal level, but a lot of times the foods and choices that we make there will make it higher. And medications will help lower that as well, so. Yeah, they help. All in your brain functionality, everything else. I don't think I put anybody to sleep, so there's plus. Last year, looking at
Yeah. Thank you so much, Becky, for that great presentation on stroke awareness. Thank you all for coming. And just a quick reminder before you all leave, November 19th is our next Healthy Living Together event. And it is going to be self-care during the holidays. It's crazy, the holidays are coming up already. So we hope that you all can join us. Thank you.